Welcome to the podcast, Not Your Doc Anymore. I am your host, Darren Watts. Here, we address the issues essential for your health and provide information to help you become your best advocate. We encourage empowerment through education. I cannot emphasize enough the power of physicians who understand clinical practice and are counseling with patients on a regular basis and have had years of experience. Here to address the topic of eating disorders is a phenomenal individual and Dr. Anna Packard. Thank you for being on this podcast.
Aw, thanks for having me. I'm excited to be here.
That's so great. Well, I'm going to just give a little bio. Dr. Anna Packard is a licensed clinical psychologist and owner of Embodied Counseling. She is a certified eating disorder specialist and certified group psychotherapist. Dr. Packard has worked with clients struggling with eating disorders and body image concerns for the last 15 years. She's worked in an inpatient residential setting for eating disorders, a college counseling center, and now for the last 9 years in private practice. Dr. Packard works with clients individually as well as in group therapy. She offers eating disorder process groups as well as body image concerning groups. Dr. Packard is passionate about helping clients heal their relationships with food, their body, and ultimately themselves. I'm going to just say that you accomplished these professional accolades all while creating a family. And I was lucky enough to take care of you through 3 of your pregnancies and deliver your children. And I love it when I see patients and when patients come up to me and they introduce their kids to me and say, "This is the person who delivered you." And I think it's great because mainly the kids look at me with a blank stare and I can hear them saying in their minds, "Should I recognize this guy?" I think it's so fun when that happens.
Yeah, that was so fun yesterday to be able. Well, I haven't seen you in so many years. Well, a lot happened for you, but also I stopped having children. And so it was fun to see you these years later and you see the kids that you helped me get here.
Amazing.
So I'm just so happy to collaborate with you, be with you. I'm a big fan of yours, have been for a long time. So
Wow, you're so nice. Well, thanks, Anna. We met prior to this interview, and I'm going to put you on the spot just a little bit, but every time I meet a psychotherapist, I always feel like I'm choosing my words and expressing wisely because I know that they're analyzing me. So I'm going to put you on the spot with this. What goes in your mind when you bump into your gynecologist socially?
what goes? Well, you're not paying me to analyze you, so I'm not analyzing you.
Okay, good.
And actually, one of the reasons I have been a fan of yours for all these years isn't just how you have been such a part of my life and helping me get my family here, but how understanding and curious and how you've cared about this topic that we're talking about today and the well-being of your clients and the well-being of people and their relationship with their bodies. So I've always just had really great thoughts about you.
Well, thank you. It was so amazing because I think we've known each other for a lot of years and I've seen you grow up in your specialty and go from where you were, I think, in a group setting or in an inpatient setting to your own private practice. So it's been amazing. I'm excited to cover this topic with you. Thanks for being with us, Anna. So I'm going to start with the first question. And feel free to elaborate as much as you like. I may interject some questions, but what are the most common types of eating disorders and how do they differ from one another? And as you address these eating disorders, will you teach us about some of the screening tools that are available for practitioners in arriving at some of these diagnoses?
So the most common types of eating disorders, I think the things you and I are going to focus on in this podcast are, I think, the more eating disorders that come to mind when people talk about eating disorders. There's eating disorders that aren't related to efforts to lose weight and body distortions. And so you and I think, are talking mostly about anorexia, bulimia, binge eating disorder, and something that encompasses all of them in a sense, which is called OSFED. So to answer the question, what are the most common types of eating disorders? The most common diagnosis is actually OSFED, and OSFED stands for Other Specified Feeding and Eating Disorder, followed by binge eating disorder. That's the other most common eating disorder. So to explain OSFED a little bit and why that's the most common is the diagnostic criteria for bulimia and anorexia are very specific, and there's some good reasons for that, but there's also reasons they don't capture people who are clinically ill and need support. So OSFED is a diagnosis that allows for people to be subclinical in some way. So for example, either with bulimia, they don't meet the duration of symptoms that's required for the actual diagnosis, or they don't binge and purge as much as needed for that actual diagnosis, but they're binging and purging, so they have an eating disorder. Or with anorexia, there's still the clinically underweight requirement that has controversy to it, which I agree with the controversy. So OSFED encompasses atypical anorexia, which is more common than anorexia. So atypical anorexia, you have all the symptoms of anorexia, including the medical concerns, but you may be of normal weight or even overweight. So what's really vulnerable for someone seeing a medical professional, they may not present with their eating disorder. That might not be why they're seeing you. They're seeing you for other reasons, but that's going to be part of the presenting profile. So what is tricky is you might be in a position of observing things that they haven't spoken to, like you've noticed, or there's a significant change in weight, or there's a significant change in lab values, or there's something funky going on with an EKG. So starting with a place of curiosity of, hey, what's changed for you? And can you tell me what's behind those changes? What are you doing? But also, what's the thought processes behind this? What's the intent behind this? And if they start endorsing specific behaviors, being able to follow those with specific follow-up questions like, oh, okay, so you're dieting. Tell me about that diet. What does that actually look like? How restrictive is that diet? How long have you been on that diet? And then asking them associated physical signs of anorexia that include really worrisome medical signs about, are they feeling dizzy? How's their blood pressure? Are they having gastrointestinal pain? Are they feeling cold? Those sorts of things leading into just, I would say, expansive interviewing. Be so curious and follow each thread that they're willing to share with you.
Is there a source that somebody can go to that they could seek out those questions that would be appropriate for them to seek it out for themselves, or for a practitioner to know maybe the appropriate questions to ask?
Yeah. So our National Eating Disorders Association, it's nationaleatingdisorders.org. They have a great screening tool. They have one that you can take as an individual if you're concerned about yourself, want to know. But there's so many good resources for medical professionals, for educators, for loved ones, family support systems as well. There's a whole host of how to get help, how to get resources, and information on eating disorders.
Okay, so let's say a practitioner has a list of those questions and is concerned and asks the question. What are the points that a practitioner needs to refer somebody to somebody like yourself? When does that happen?
So I think about a couple of things when I assess clinical relevance, for lack of better language. I think about how distressed is my client or is this person about this thing that's happening? How distressed are they about their eating habits or about how they feel in their body or how their body looks? How long has this been happening? So has this been something they've been struggling with for a while, or does this feel pretty new? How much is this interrupting their life? Are they able to function? Is it occupying a lot of their mental energy? I'm actually talking specifically, we call it the Ds in clinical psychologists, and it's distress, duration, deviance, danger, and dysfunction. So the interesting part about deviance is it doesn't really apply because people with eating disorders are often doing very socially endorsed behaviors. And so they're being reinforced for it. But so I think about the distress piece, the duration piece, the dysfunction piece, and the danger piece. All eating disorders can be very dangerous and are life-threatening at a certain point.
Okay.
But I think about
What do you mean by the socially endorsed? In other words, it's socially acceptable?
Yeah, well, I mean, as we were starting talking about anorexia specifically, the restriction component of anorexia is people envy their ability to be so controlled around food. And that is very reinforcing for them. People are asking them, how do you do that? Something that is so hard for me to hear in out and about when I'm out in the community, when people say, I wish I could have an eating disorder. I wish I could have that level of
Mm,
muscle. I'm like, oh, you don't know what you're actually saying, because this is a very painful experience for people. But people often witness these people as being very successful and um, reinforce it through commenting on how great they look or how jealous they are of how much
sure.
control they have. So that's why I'm saying it's not deviant from what society expects.
Okay. So you touched a little bit when we talked about all of the eating disorders that OSFED is the most consistent. Let's maybe focus on that just a little bit. And what percentages of the population are we thinking about here? And how do we get to that diagnosis of OSFED?
So OSFED is applicable to individuals who are experiencing significant distress due to symptoms that are similar to disorders. So such as anorexia, bulimia, binge eating disorder, but it also includes things like orthorexia. It includes purging disorder, which also is in the DSM right now. And it includes exercise addiction. So it's a bigger umbrella for eating disorders. So when you ask percentage, that's hard because we don't necessarily have the striations of those different. But what I can say is over the course of people's lifetime, if you live in America, we've got 30 million Americans that are going to have an eating disorder in their lifetime. And right now, that's about 9% of America has an eating disorder, diagnosable eating disorder.
Gotcha. What's orthorexia?
Orthorexia is a big obsession, rigidity around clean eating. When we're thinking of those D's, it has taken over their life. This isn't just a lifestyle. This is they can't eat out with friends because that's so distressing because what they're eating isn't clean enough, pure enough, close enough to Mother Earth.
How about for bulimia? Maybe what are some of the screening tools that are available for practitioners and listeners to be able to say, maybe this is something that I need to be aware of?
Yeah. So bulimia, I would love to talk more to dentists. When I do run into dentists, they're often the ones that see the evidence of it, right? Because if you're purging a lot, you're interfering with the health of your teeth.
The acid that rots your teeth?
Yeah. So to meet criteria for bulimia, there's at least one binge purge episode a week for at least 3 months.
Okay.
And a binge, people often have a lot of questions about what a binge is. A lot of people think they are binging, but they're just overeating or mindlessly eating. A binge is considered eating in a short amount of time, an excessive amount of what other people would consider normal in that amount of time. And it includes other things like feeling out of control when you're eating. A lot of my clients describe feeling numb or even dissociated around those eating episodes. There's a sense of accompanying guilt and shame, eating past the sensation of fullness into pain, and a lot of regret afterwards, which is where the compensatory behaviors come in. So bulimia doesn't just include purging. People use other forms to compensate for calorie consumed, whether that be laxatives. Exercise can be a form of purging. There are other ways to do that. So those are the behaviors when we're talking bulimia.
Okay. Can you explain some of the potential causes and risk factors for developing an eating disorder?
Yes. Basically being a human in our culture.
Okay.
You
Living.
So there are several. We can think about it in terms of a biopsychosocial model is a good way to capture it. So there are biological risk factors, there are psychological risk factors, there are social risk factors to reduce it. There's a significant hereditary component to eating disorder. So having a family member who has a history of an eating disorder makes you more likely. Having a family culture of dieting, having a trait of perfectionism makes you vulnerable. Having traits of impulsivity create vulnerabilities. One of the episodes you did with Taylor Dunn, I know she talked about the history of dieting being a vulnerability. That is one of the biggest vulnerability factors. Almost all eating disorders start with a diet. And we talk about this cascading effect that it leads to chronic dieting, which can lead to eating disorder behaviors. So again, when we live in a very heavy diet culture, that is part of why I say, well, just being alive makes you vulnerable for an eating disorder. And we can talk specifically about that, but other things that make you vulnerable. Eating disorders have a lot of comorbidities with them, and comorbidities are other mental health concerns. So there's a strong overlap of depression, anxiety, history of trauma, OCD, cross addictions with other substances. All of that creates increased vulnerability for eating disorders. Athletes, for I think pretty intuitive reasons, are increased likelihood for eating disorder. History of being teased or bullied. We could spend an entire hour just on what creates vulnerabilities for eating disorders. So sadly, there are a lot of vulnerabilities that can give rise to eating disorders.
All right. Well, let's discuss a proper evaluation medically. The first is a complete blood cell count. That would include your white blood cell count, make sure you're not anemic, with a differential, and a urine analysis.
We see a lot of anemia. And in fact, almost all our clients are exhausted. But what's hard is they may blame anemia, but it's also, well, you're also not nourishing appropriately. So we're
Yeah.
missing important fuel on board for why you're exhausted too.
Then you wrote a complete metabolic profile, which includes sodium, chloride, potassium, glucose, a BUN, a creatinine, total protein, albumin. Looks like testing your liver as well, AST and ALT, and an ALK phos, and a total bilirubin.
So part of why we send our clients for these labs specifically, as well as an EKG, is to assess the severity and medical stability of their eating disorder. I joke with my clients, though, that I'm not that kind of doctor. So I let the doctors tell me what's happening with the clients and what the lab values mean.
I'm just going to add these just so that everybody knows, but serum magnesium and a phosphorus and thyroid, T3, T4, and a TSH. And then you mentioned EKG. In the recent years, have you noticed any emerging trends or changes in the prevalence or of particular eating disorders?
So sadly, the global incidence of eating disorders or prevalence rate of eating disorders has increased. It's over doubled between 2000 and 2018. So it's not getting better, it's getting worse. The global eating disorder prevalence rate was 3.5% in 2000, and it was 7.8% in 2018. So it's increasing across the world. It used to be considered like a first world problem. It's increasing in prevalence. One of the things that I think is really humbling is a statistic that every hour someone dies as a direct consequence of an eating disorder worldwide. It used to be that eating disorders had the highest mortality rate of any mental illness. That has changed. It is now second to opiate addiction. It's not because we're doing a better job at helping people recover and live well. It is just that the opiate epidemic has gotten so much worse. One of the other things I think that is interesting and sad is the rates of eating disorders are rising faster for males than females at this point.
Really?
And in the LGBTQ community as well.
Interesting. Okay. How has social media, you feel, influenced the way people perceive body image and eating habits, both positively and negatively?
Great question. I have a lot of thoughts about this.
Okay.
One thing I like to zoom back a second, though, is to talk about a landmark study that shows us just the impact of media, Western media in general, that will set the stage then to talk about social media specifically. So we had this really cool, I say we, I didn't do this, but
you're owning it. That's good.
Yeah. People in my world did this amazing landmark study that was so informative and helpful for all of us to understand the impact of media on people's relationship with their bodies. So in the mid-90s, TV was just introduced into Fiji in 1995. So prior to 1995, there was no TV in Fiji. And what we know about Fiji as a culture, they actually have a value around larger bodies. They have a good value around food, and food serving so many purposes with connection and culture. And then in 1995, in comes TV, and researchers collected data 3 years later, so 1998. So when we went to Fiji, and before that, there was almost zero incident of eating disorders or dieting in the culture. 3 years later, just 3 years of exposure, these were teenage girls, you went to 74% of adolescent girls reporting they were too big or too fat. and you suddenly went to a high incidence of dieting. 62% of the adolescents were reporting they were dieting, coming in just 3 years of that exposure. And upwards of 45% of the adolescent girls reported purging in the last month. We can say pretty directly how media influences how people view their body, and there are anecdotes about how they were directly comparing themselves to the women they saw on TV. Okay, so now we're talking about social media, which is its own special, unique beast. So originally people on TV, they are by majority underweight. I meet this cultural idealized image of beauty. And now we have social media, where the good parts of social media is it does serve a good connective function. A lot of people report feeling connected, staying connected to family, friends across time and space. And we also know that consuming social media as little as 30 minutes a day can change how you view your body. And teenagers, especially, but also all people, are consuming it way more than 30 minutes a day. So you suddenly have, it's not just beautiful people on TV, you're watching your friends with their selfies, their filters, their ideal moments. And it just breeds a lot of life comparison, but also body comparison that leads to a really unhealthy relationship. There's actually several lawsuits that were happening against Meta for harm that can come from the algorithm. It's not just your friends, but the algorithm will give you images and reels that promote dieting and promote even unhealthier ways of being in your body. One research study found that Instagram made body image worse for 1 in 3 girls. Good news is I think there's increased awareness. There are some things that are changing in social media. When I played around in the space, they were still pretty toxic. I made a fake account once to just see what I could go find, and it was really shocking. But they do try to limit access to information about social media. Can be a place where people get ideas to better their eating disorders, to make them worse. So there's like pro-anorexia sites, there's pro-bulimia sites. Social media is trying to block those, but they're not that hard to get around. So I think it's a very vulnerable space. All my clients, I've never heard a client say, I was really mentally more healthy on social media. A lot, I hear more often
Yeah.
that when there's good boundaries or even off of it completely, there's a lot more freedom and peace and less comparison that happens.
Interesting. So when you said you've created a fake account and it was shocking, like what are the things that you saw that were shocking?
You can search hashtags, right? So there are what I eat in a day is one trend that I was looking at, and it's people really talking about how to restrict under this guise of like lifestyle influence, athletic influencer. There are a ton of underweight photos. There's a ton of, you can just change letters into numbers and look up the same information. So you can change anorexia with make a 0 in there, and you can get around stuff. It did try to warn me. Some of the sites, it said there's sensitive content, and if you need help, I think it even maybe offered a resource, but then you have the button of continue with content anyway.
Yeah.
So it's not the biggest barrier, but I appreciate that there was an attempt there.
Sure.
So they know if clients are interested in eating disorder sites, they know how to find them. They're still there.
Sure. So let's take it outside of social media. Have we seen an increase in concerns with Ozempic being used more consistently around in our culture? What are your thoughts on that?
I am so interested in the data we're going to keep getting on the use of Ozempic and how that impacts eating disorders. My opinion on this is I am very nervous that we're going to create more eating disorders than solve for a couple of reasons. And Ozempic takes away our intuitive relationship with our body cues and leads to actual restriction, which leads to weight loss, which is the point. I know Ozempic works in other ways. I don't mean to be as reductionistic as that, but it does decrease hunger cues. You create a situation in which someone no longer is attuned to their body. If people don't want to be on Ozempic forever, you're going to have what happens with all diets, where you go off of it and suddenly your experience with your body is so misattuned that it will lead to rebound weight gain or voracious hunger, or also over control, which we see on the restrictive side of eating disorder. It also interferes with our dopamine, our ability to enjoy food, which is a healthy experience of being a human. We want to be reinforced to eat, and we're ruining joy for food. So I worry about that. I hope doctors are being incredibly cautious and thoughtful about prescribing Ozempic for people with a history of eating disorders. But I also think we're going to create people who didn't have eating disorders. They may have developed an eating disorder either on Ozempic because it's so much easier to restrict, or when they go off of Ozempic and try to have a relationship with food again.
Okay. I know we talked briefly about this, and I'm just we're going to stick on this topic for just a little bit. But the book, Good Energy, by, I believe, Casey Means and her brother, I can't remember his name. I have my own opinions about it, but tell me how that has potentially affected patients you're seeing, or maybe your conversations with your colleagues.
Oh, yeah, we have lots of feelings about this book. To be fair, I haven't read the book. I've listened to a few of her podcasts. It's on my to read list too. So I can't give specific comments, but I have heard her speak on multiple podcast platforms about content. And I have heard from several clients who have read the book. The world I swim in is unique in that it's so dangerous to vilify food. Vilifying food is the most triggering thing you can do for someone who's trying to recover from an eating disorder. But I also think in general, for us as humans, I don't think it's a good idea to create rigid relationships with food and associated moral relationships with food about like there's bad food and good food. That creates not just an intuitive way of understanding how food makes you feel. You have every right to eat in a way that makes you feel good in your body. I'm about that. But when something external to us tells us that way, again, we're disconnecting from our own lived experience in our body and what our bodies need and how we need to function. But then you infuse a morality component, like I am not good, I am bad for eating that thing. And we're creating a cascading effect of problems, ultimately also that can lead to eating disorders or worsening of eating disorders.
Gotcha. Okay. Well, thank you. That may be a whole separate conversation. So what are some early warning signs that someone might be developing an eating disorder?
Okay, so things you're going to see with someone who may be developing an eating disorder, you're going to see preoccupation with weight loss. You're going to see preoccupation with food. They may be counting calories. You're going to see dieting. You're going to see refusal to eat certain foods. You may see them eliminate whole food groups. Again, this is where it gets confusing because they may say I'm following the keto diet, or I'm doing clean eating, or right. And so there's reasons to dismiss it or get confused on what's the intent really with what they're doing. Sorry, this is a quick tangent, but I always talk about when we're talking about food and exercise, I think the why behind the what is incredibly important. I mean, in general, I follow intuitive eating guidelines. I loved your episode with Taylor Dunn. I think dieting is so problematic for so many different reasons. And really why someone's dieting is perhaps more important than what the diet is.
Sure.
So are they doing it for weight loss? Are they doing it because they believe they will feel worthy if they achieve this goal? Versus I'm trying to feel better in my body, or I have this specific condition that would benefit from eating a different way. So you're also going to see food rituals. I love knowing certain things like how they'll chew a certain number of times. Like they'll chew a lot to slow down their eating, or they're cutting things up into really small sizes to slow down their eating. But other things that are more obvious, like you see people starting to withdraw from friends, or they're stopping, they're not doing the things they normally would do, or they're not willing to be flexible with like their exercise habits, and they'll miss out on things because they have to get this workout in. You're seeing a lot of body checking. So comments when they looking in the mirror a lot, making comments out loud a lot, feeling different parts of their bodies, hiding their body in a lot of layers, wearing sweatpants and sweatshirts. increasing rigidity of exercise habits. You're going to see depression and anxiety as well in part of those warning signs. Those are just some of them.
Sounds good. I feel like I'm worried about myself now with a lot of those lists that you just created.
We need to have a different conversation, Darren. I'm here for it.
I love it. How can friends and family members best approach someone that they're concerned about who might be struggling with an eating disorder?
I think that's such a good question. I know there's a lot of anxiety from friends and family members about approaching someone they observe eating concerns or changes in weight, mostly because it feels invasive or taboo. I think the only wrong thing to do is to not say anything. And I say that with a lot of compassion. I don't mean to shame. Again, I know how hard it can be to bring such a vulnerable topic, but I would really, first of all, just give yourself permission to do it messily. We're all human. Having these kind of conversations are really hard, but approaching it from a place of compassion as well as curiosity in a non-confrontive way. So sharing like, hey, I've noticed these behaviors, and then give them specifically like, hey, I've noticed skipping meal times, or hey, I've noticed there's been body changes for you, and I'm worried about you. Can we talk about what's going on for you? And also have, hey, I would love to help you find support. I'd love to help you find resources. I think it can, something that can be hard sometimes, especially for teenagers. If someone does open up about their eating concerns, it can be easy for friends to feel like they're going to support them and help them change. So knowing the limits of your capacity, you're not there to be their dietitian. You can be supportive, but also knowing like, hey, I'm going to help you get the help you need. When we talk about going back to those Ds, a lot of times people need to feel distress before they're able to talk about it. So you might meet a lot of defensiveness at first, but I think it also matters that people know you care and that you're witnessing what's happening for them. But they may not be experiencing the distress yet or want help yet.
Okay. That's great. Thank you so much. Great answer. What are some of the most effective treatment options that we have available for individuals that are dealing with eating disorders? And maybe where do we start?
Yeah. One of the first things I do as a clinician, blanket statement, multidisciplinary treatment has the best outcome for people with eating disorders. One of the first things I do as a clinician is I need to know what level of care they need, because some people are so ill, they're going to need inpatient to make sure that they're safe medically to do the recovery process, or at least for a certain amount of time. So that's part of our assessment and part of why we refer to physicians to get some of these lab work done. But for me and my fellow colleagues in this space, we work with an individual therapist, a dietitian who is knowledgeable in treating eating disorders, a medical physician who's going to monitor their physical health. And then we often have psychiatrists on board, and we have group therapy as well as a resource.
Gotcha. And what can somebody plan on as far a time frame? I mean, these are probably ingrained behaviors over maybe years.
That is such a good question, because so much of recovery depends on different variables. Like you pointed out, how long have they been struggling with this? The earlier we can catch an eating disorder in general, the better and quicker they're able to recover. What kind of resources and support do they have in their life? How easily access do they have to care? What is the eating disorder? The different eating disorders have different trajectories. For example, anorexia, the average length of treatment is 7 years. For bulimia, it's 3. So just inherently, you may be working with something that has more longevity to it and harder to dismantle. I also think one of the biggest things I work with clients is understanding the function of eating disorders. Unlike a lot of other mental health concerns where it feels like there's nothing positive about being depressed or anxious, eating disorders have a lot of functional components to them. So what is the function? Are they managing trauma through their eating disorder? Are they managing a lot of mental health concerns? Are they managing a lot of relational distress? So all these variables will depend on what we're tackling clinically in terms
Gotcha.
of the recovery process. Because it's not just we're going to get you eating normally again. In eating normally again, we're going to uncover all of the things that your eating disorder was working to help you not feel around or function around. So
Right.
it depends.
That's a great answer.
Let me say one thing though. I know it can feel really overwhelming, especially those statistics on how long. There's a lot of variability. So again, how motivated someone is matters a lot. How committed they are to the process and their willingness to do some hard things can really speed up their recovery process. But I also think it's helpful to validate that recovery from an eating disorder is one of the hardest things to recover from. And there can be relapse and it can be a long journey. And I wouldn't do this if I didn't believe and have a lot of hope for people, as well as see people recover and go on to
Yeah,
live full, healed lives.
it's hopeful. I love that. Can you share some insights into the role of multidisciplinary teams?
Yeah, I think the only thing I might add about that is talking about dietitians. I really value my relationship with the dietitians that work with my clients. I talk about here's my lane that I try to stay in. Again, I'm not that kind of doctor, so I need you to go get medically assessed, but also in terms of food, I have some working knowledge, but I am not an expert. And I need their expertise to support the behavioral change of my clients and help them stay accountable. And then I get to do the work of helping them remove barriers and their distress around the things that dietitians are asking them to do, but then also all the psychological underlying reasons for their eating disorder. So I get to do that work with them as long as they're being compliant with a dietitian. And when we talk about the importance of nourishment and chronic nourishment in doing the psychological work, a lot of clients will want to talk about their trauma or work on their underlying concerns. And I talk about it's really hard for a malnourished brain to do that kind of work. Physically and emotionally, you're not capable. So I really need the dietitian support. This is the team approach, and to have eyes on with the dietitians, get direct accountability through their food logs and their weighing my clients so that I don't have to be the detective to know what they're doing or not doing, but we do get to work on that other stuff that will lend to recovery.
Okay. All right. For physicians, since I have been in that role for so many years, what are the best things that physicians can do to make sure that patients are getting help? And maybe what are some of the bad scenarios that occur with physicians that are happening out there?
So one thing that I think is important to note is the vast majority of people with eating disorders are in normal sized bodies or larger bodies. Over 90% of people with eating disorders are in normal
Okay.
sized bodies, larger bodies. So, what can feel really vulnerable or is really vulnerable for clients to see medical professionals who will endorse weight loss for them, even give them diet ideas or tell them that they need to lose weight. That can be obviously very shaming and triggering for a client that already has a very poor relationship with food or already is doing the things that doctor is telling them they should be doing
Mm.
to the extreme even, right?
Right.
I would like to increase awareness around decreasing reliance on the BMI as this focal point of health for people and taking a more aggregate, holistic view of what's happening for them. So doctors that are informed from a health at every size perspective in treating patients and their concerns legitimately, really not being quick to endorse diets. Again, I loved your episode with Taylor. Diets in general are very problematic and don't solve a lot of what doctors are hoping they'll solve. So doctors being really curious, working with patients around their needs and relationship with food. Also, doctors who, if you are seeing someone who's clinically underweight, I've heard often, oh, your heart rate's low because you're an athlete. It's like, oh, actually their heart rate's low because they're really sick. Or yeah, you lost your period because you're such an athlete or you're an endurance runner. And it's like, well, actually, no, they're also very undernourished. So checking our own assumptions about wellness and the symptoms of wellness and normalizing, no, losing your period is a big deal. Let's actually talk about that. Or having a low heart rate. Let's actually explore that a little bit more. So just being a bit more curious and thoughtful about what our clients are presenting with.
I love that. Thank you. Has the pandemic affected individuals with eating disorders, and what challenges have arisen as a result of this kind of crazy time in our life?
Yeah, the pandemic made eating disorders worse. It's the short and pretty clearly made them worse. Anecdotally, my clients all reported that, but we also saw the research and the reports on it making them worse. Most also in intensity, but also more people having them. The why around that was for a couple of reasons. I think there's some controversy, but there was some community nationwide weight gain associated with COVID. I think from being isolated, being disrupted, changing our relationship with food. So that obviously causes a lot of distress for people with eating disorders when people are gaining weight and talking about gaining weight, but also being isolated, not having your routine, being at home, not moving as much, but also your scales at home, right? There's just a lot of triggers. And then COVID also was really hard when my clients would get COVID and lose their taste and smell. That is the problem when I want them to enjoy food, but everything tastes like sawdust, right? And it's already a barrier to enjoying food, period, overcoming the anxiety associated with eating. But then if they can't smell or taste it, it was even harder. And just in general, all the anxiety that we experienced globally. One of the functions of eating disorders is to manage anxiety, and they do it pretty well. And so that also was part of what they were doing, functioning to help manage anxiety. I had clients joke at the time about how, oh, the world actually is now feeling how I've always felt. Like, welcome to anxiety, everyone. And,
have there been any adaptations in our treatment approaches due to the pandemic?
Yeah. I think the main thing that I think was a good move is really quickly there is more access to services online. So I was able to offer therapy through teletherapy, dietitians. We all did some creative work to continue to work as a treatment team and see our clients regularly, even if it wasn't ideal. And in fact, some clients, for reasons that are understandable, but I want to challenge, is they prefer online because there is less vulnerability is showing up in your body in your clinician's office. Is why I like to challenge it. But I also really value that can be something, again, when I want to remove barriers to access to treatment, teletherapy has been a really vital part of that.
Yeah, it's great. You can do an interview with a nice shirt and no pants, right?
Exactly.
That's right. All right. There's a lot of discussion online about clean eating and extreme dieting. How can these trends inadvertently contribute to an eating disorder?
Well, clean eating denotes that there's an unclean way of eating. And going back to kind of what we talked about, that creates a sense of morality around food that can be harmful psychologically for us and disconnect us from the inherent reciprocal relationship of our body's attunement to food and how we feel with food. So clean eating, taken to the extreme, this is what we were talking about earlier. This is where it can lead to orthorexia. Anytime you're cutting out specific food groups and getting more rigid around food, I mean, best case scenario, people are decreasing their enjoyment with food, their accessibility to the other reasons we eat, like communing with people, of celebrating. So that's best case scenario, and it still really sucks. Worst case scenario, you're creating a psychological relationship with food, good food, bad food, which leads to rigid eating and restriction, which then leads down that lovely staircase of increased distress and behaviors around food.
That's a great answer. What resources or support systems do you recommend for individuals seeking help for themselves or for their loved ones?
Again, the National Eating Disorders Association, I think, is a very user-friendly website with a lot of good resources and tips on there. So I often will send people to those. You can find certified practitioners. So they're certified eating disorders therapists, they're certified dietitians. And that's all found on a national listserv through IADEP, the International Association of Eating Disorder Professionals, if you wanted to find someone locally who has that expertise. I think of this trifecta of reading resources that I like to give clients as well as their family. So one is Intuitive Eating by Tribole and Resch, which is a really great manual to talk about how, one, we're originally wired to have a healthy relationship with food in our bodies and how we get in the way of that, but how to repair it with these different steps. And then Anti-Diet by Christy Harrison is a really good book that helps explain the problems inherent in dieting and how they create more problems than they solve. So if we need to dismantle our own biases and attitudes, that's a good one I like. And then
Okay.
Body Acceptance, a book I often refer to as More Than a Body by Lindsay and Lexi Kite, which is a good one to talk about self-objectification and how we can have a different relationship with our body.
Those are great. I love those. Got some new reading lists. How can healthcare providers work to reduce the stigma associated with eating disorders?
I think one of the great ways health providers can is really taking clients' experience with their body and food seriously, regardless of their size and weight. So going back to understanding that most of the people suffering won't look like they're suffering in the traditional anorexic idea of eating disorders. And so being really open and curious and supportive can be life-saving. I know when my clients find health providers who are so thoughtful and take time with them and do things like blind weigh them, that can be so safe and validating and make you trust and open up to your health professional more. So that means either the client turns around on the scale, so they're not watching what the number is either, and whoever noting the number keeps that hidden from the client, and making sure that when you're in the room with the client and their data is up, they're not easily seeing what their weight is. And also not talking about it unless it's a significant concern. Hey, there's been a significant change here. Let's explore this. Or is, when you ask as a professional, is there anything you're worried about? Letting them lead, like, hey, yeah, I'm worried about my weight. Well, what about your weight? What about that concerns you? So yeah, I think all that can create a lot of safety and decrease stigma for seeking help.
That's great. I have to say, as an obstetrician, that's the one thing that really bothered me a lot is putting a patient on the scale every visit. And I know there's a lot of providers out there that would make big deal of like, hey, you're gaining too much weight or you're gaining too little weight. And I just think the body does its job in growing that baby regardless of the weight. I think to me, the biggest issue was, do they have signs of preeclampsia, which can give you this
Right.
massive weight gain in a short period of time? I don't know. I feel like looking at the scale for obstetricians is just a fruitless endeavor.
Yeah, I appreciate that. Ironically, the only time I ever know my weight was when I was pregnant and seeing
Yeah,
you, because I don't own a scale. I don't have any medical reason to know my weight. And I'm really clear that literally the pull of gravity on my body doesn't tell me anything, but I need to know about my sense of worth or how I'm doing in this world. So I talk a lot with clients actually about if they own a scale or if they do weigh themselves, really doing an honest confrontation about why they're weighing themselves and what that does for them. So I love what you're talking about too, because I think in the medical world, we need to think more about why we're collecting this data. Where is it really necessary? And it absolutely is necessary in certain circumstances,
sure.
but how easily and reflexive we do that when we don't need to. And also patients knowing they can opt out of having that data collected. They don't have to
Sure.
wait unless, again, there's a good reason. But yeah, I'm with you. I think the
Yeah.
scale is sort of like diets. It creates more problems than it solves.
Yeah. I love that. A blind way. Had a lot of patients who would stand opposite. I never really quite understood that why, but I think it's a great practice.
Yeah, I agree.
Is there any current research that suggests that there's a biological or genetic component to eating disorders?
Yeah, we did cover some of this. Some other points that I think are interesting that have been emerging in recent years has been the increased understanding of prevalence of neurodiversity and eating disorders. There's a
Hmm.
significant relationship there that we're beginning to understand. So people on the autism spectrum, as well as ADHD, there's a strong relationship between those, and understanding the role of dopamine in, well, like ADHD, as well as sensory concerns and executive function. We're all continuing to understand the role of the brain in working with eating disorders, but I think that's emerging information that can be really helpful with guiding treatment.
Great. Are there any promising new treatments or interventions that you've seen on the horizon that you're particularly excited about?
Yeah, I don't know how controversial this is to talk on your podcast, but I am excited about the frontiers of psychedelics,
Okay.
in mental health concerns. So specifically for eating disorders, what I've seen is some evidence about ketamine and psilocybin. So, why those are exciting? When we think about eating disorders, can be some of the most rigidly entrenched belief systems that have been potentially reinforced for decades when we're talking about treatment. And so here I am as your psychologist trying to help you with cognitive flexibility and emotional coping tools and regulation and hoping you heal trauma. We're asking a lot of a client and a brain that has been doing something very specifically and, like I said, in some ways very functionally for a long
Yeah.
time. Whereas
Yeah.
psychedelics, what feels really promising, I like the metaphor that they're sort of like shaking the snow globe, where if all of our neural pathways are like going down really familiar, well pat down ski trails. So unless you're working really, really hard, your default's going to be what your brain knows. And psychedelics allow for a reset and a fresh layer of snow. So it just makes it easier to lay down new networks and then follow and build momentum on those. That feels really hopeful. Ketamine is being used for the treatment of eating disorders, but obviously psilocybin is still not legalized in the US. Anyway, so that world is emerging. I'm certainly not going to endorse it because it's not legal, but I think what's coming out is really hopeful. And the studies that are being done in really legitimate places like Johns Hopkins, I'm really excited to see.
Okay. Interesting. We'll see. What are the 5 things as a summary that you would like listeners to know to help them better understand eating disorders? These are Dr. Packard's final 5 things.
Well, first thing, eating disorders are not superficial. They're not just about food and weight. They're multi-layered and complicated. And I love that because I just have such deep respect for the work people are confronting when they choose to recover from an eating disorder. It is not just to choose to have a normal relationship with food. It is about healing so much more. 2, eating disorders don't look a specific way. So people who have eating disorders come in all body types, genders, ages, abilities, and races. Also, whether someone has a full diagnosable eating disorder or someone that has a disordered eating and wants to heal their relationship with food and their body, I hope everyone knows they are worthy of treatment and healing.
All right.
3, there is hope for recovery. I know we talked earlier and it can feel overwhelming, but I really just want to pin there is absolutely hope for recovery from eating disorders. And then 4, one of the common factors I see across all my clients and in all the years I've worked with eating disorders is not feeling worthy to take up one's deserved space in this world, both literally and metaphorically. I love part of healing from eating disorders is stepping into our own inherent worthiness as humans to take up space. And then finally, that relates to my last one, which is eating disorders are evidence of sickness in our own society. So I hope that we can all continue to dismantle our own biases about weight and food so that our society is a much more welcoming place for body diversity.
That's a great summary. Thank you so much.
Yeah.
This is a new segment of the podcast. I'm calling it the Delta segment. We are human as providers. And I just need to ask you this. How has taking care of patients with these conditions changed you?
Wow, such a good question and such a big question. There's this fantasy I have for myself that if I could ever write a book, the book would actually be about how my clients have changed me and what I have learned from them, not about how I help them change or what I believe I've taught them, because I do believe I get so much from the work with every single client. I think I am continually humbled and honored and impressed by people's bravery, capacity, and resiliency. I have the best job in the world that I get a front seat seeing how brave and resilient and capable people really are. There aren't good words to express how incredible humans are in their ability to do hard things.
Yeah, that is so true. I love that expression. Thank you.
Yeah.
I know that people possessing the real knowledge for the current medical system are those working within the system, like yourself, not people just looking at numbers. And so I'm going to ask you if you could fix what some people refer to as the broken healthcare system, what steps would you want to make to change the delivery of healthcare to your patients?
Oh, man. Okay. I think first and foremost, there needs to be better insurance coverage, period. When I worked at an inpatient clinic, I remember part of the work was how to help clients get the care they need. And it was an ever evolving, but always chronic advocacy work with insurance to help them know this client still deserves this level of care and needs this level of care, even if they're weight restored, right? Weight restoration is the first part. Renourishment is the first part of a longer journey. So better insurance coverage, including outpatient. I hear regularly, oh, my insurance no longer covers my dietary sessions. If insurance covers individual therapy, it's very time limited. When I said anorexia takes on average 7 years, we're not going to get very far when only 12 sessions are covered, right?
Yeah.
I could say one thing, that. But also, I think there's a lot of increased need for awareness and support in the community from things like more collaboration with physicians, more awareness, education for physicians around eating disorders, more collaborations with professionals like us. So we know I am always looking for physicians that are quote unquote safe for me to send my clients to, who won't increase their shame, that will take their concerns seriously and be really thoughtful about their care. I need an increased referral list for that. So more education for doctors, and what you're doing is perfect. Other fantasies include things like childcare for higher level of care for clients. So many of my clients are moms who may need a higher level of care, but they can't. That is such a high thing to ask of a parent, to leave a child or figure out other childcare options to get the care they need. I'm like, why don't we have more accessible childcare for people needing eating disorder treatment, or even eating support so people can do more recovering on an outpatient basis? So we've got the dietitians telling them what to do. It's really hard to do on your own. Are there people we can train and be paid by insurance to eat with our clients, support them outside of sessions? Those sorts of things would be amazing to help facilitate people's recovery, including also the group therapy I offer. Can insurance cover group therapy, and understand that's an important space of treatment for clients? This isn't just a nice place to commiserate with other people. This is actually a really vital space to get support and accountability too.
I love it. Those are great suggestions. Thank you very much. We're just going to conclude, and I just want to have this final charge to our listeners. Use this knowledge to go forward and improve your health. Seek out a healthcare provider that can get you the most appropriate screening, or urge a loved one to do the same. If you're a healthcare provider, go forward with a greater knowledge to deliver the best healthcare in one of the most vulnerable and essential interactions with those entrusted to your care. And we just need to clarify that the medical advice or the procedures do not substitute for your own professional medical consultation. In addition, listeners or viewers need to be aware of the limitations of the information that we've provided generally. You can find this on Apple Podcasts, Spotify, Amazon Music, and YouTube at Not Your Doc Anymore. You can also find us on Instagram and TikTok at Not Your Doc Pod or Doc Watts. We need to just thank all those who've made this possible. Natalie Watts, our president and CEO of Not Your Doc Anymore LLC, and our social media managers, Taylor Seberg, Emily Brown, Sarah Marion, and our production manager, Joshua Watts.